Hello everybody, this is Dr. Nadeem and we are with NEURO-PATH Lectures, the Pursue series. All our lectures available on YouTube. We have a Telegram group which you can join to access all lecture related information. We have a Google Drive where the PDF of all lectures are uploaded and you can always access them. And the master integration key helps you in navigating between the PDF and the YouTube. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we have with Pursue 7R, which is neuropathology, and the topic of the day is brain trauma. And we are streaming from IPGMER, Kolkata, India. And to talk on today's topic, we have Dr. Shristi Butta. She's an MBBS honors gold medalist, MD pathology. Presently, she's a demonstrator in Oncopathology unit of the Department of Pathology, IPGMER, and SSKM Hospital, Kolkata. She's got 12 publications in national and international journals. Her special interest is neuropathology, molecular genetics, and hematopathology. So I would request Dr. Shristi Butta, ma'am, please start your talk on brain trauma. Over to you. Thank you so much.
A very good morning. Welcome back to our Neuropathology series of lectures, and this is the Neuropathology Module 4. We are all set to discuss about brain trauma today. So what do we plan to talk today? We plan to discuss about the traumatic brain injury, particularly the epidural hematomas and the subdural hematomas. We also plan to discuss a little bit about subarachnoid hemorrhage, which has also been covered in the previous class. Axonal injury, the microscopic picture of it, chronic traumatic encephalopathy, shaken baby syndrome, and finally, the effects of the traumatic brain injury. So let's start. What is a traumatic brain injury and how does it result? There are two particular mechanisms. One is the impact and the other is the movement of the brain inside the skull. Mechanical forces transmitted to the underlying brain compress or lacerate its surface and cause ripples of shock waves that travel through it and injure parts remote from the impact. So look at this picture. Let me just show you with a laser pointer. Two types of hemorrhages or hematomas rather have been shown here. One is an epidural hematoma occurring in the epidural space, pushing the dura towards the inner side. Whereas this is a subdural hematoma occurring just beneath the dura and pushing the dura towards the periphery. Any of which results in characteristic compression of the brain and raises the intracranial pressure. There are some other lesions such as contusions and diffuse axonal injury which cause structural brain damage. So let's see. A trauma induces neurochemical alterations as well that disturb the cerebral blood flow, increase vascular permeability, and they also produce characteristic beta amyloid precursor proteins. Structural lesions induce neuroinflammation. So these secondary changes compound the mechanical effects of trauma. The most important secondary process in a traumatic brain injury are the hypoxic ischemic encephalopathy, which has been discussed in the previous class, and the increased intracranial pressure. So it is to be noted that the hypoxic ischemic encephalopathy and focal ischemic lesions are caused by cardiorespiratory arrest occurring in severe concussion, as well as by the release of the excitatory neurotransmitter, which is particularly the glutamate by the neurons in the synaptic cleft. So, the mortality in the immediate post-traumatic period is mainly due to the rise in the intracranial pressure and hypoxic ischemic encephalopathy. Survivors of severe traumatic brain injury usually develop seizures, focal neurological deficits, dementia, or even a persistent vegetative state. Trauma must also be noted as a significant risk factor for Alzheimer's disease. Now, coming to epidural hematoma. There is no epidural space between the skull or the dura. It must be noted that the dura is adherent to the skull. Fracture of the inner table of the skull can tear the arteries and veins that run between the dura and the skull, so resulting in what is called as epidural hematoma. However, it must be noted that there is a natural epidural space around the spinal cord. Therefore, a spinal epidural hematoma may occur as a result of trauma, but may also develop spontaneously in patients with bleeding disorders. Epidural hematoma characteristically involves the middle meningeal vessels. So look at this picture. The picture shown here is taken from Robinson-Cotran, and it shows a characteristic epidural hematoma. It must be noted that there is no epidural space that naturally exists between the skull and the dura. It is only when there is a traumatic rupture of the vessels between the dura and the skull is this hematoma characteristically develops and pushes the dura towards the inner side. Now coming to the brain autopsy findings. What do you see here? You see the characteristic epidural hematoma here that has developed between the dura and the skull. The hematoma has pushed the dura towards the inner side. This is another picture showing the epidural hematoma, which is diagrammatically represented here. On the other hand, this is an autopsy finding of a case where the blood clot is seen over the external surface of the dura within the cranial cavity after removing the top of the skull. Okay, so this is the autopsy finding where the top of the skull has been removed and there is a characteristic hematoma that is seen on the external surface of the dura. This is another picture where you see that the dura has been pushed towards the inner side and there is a hematoma that has developed between the dura and the skull, right? Due to the bleeding from the middle meningeal vessels, right? Now, what is an acute epidural hematoma? A spontaneous acute epidural hematoma, besides trauma, may also be seen in infections of the adjoining sinuses, dural vascular anomalies, tumors, or coagulopathies, right? So there are some common primary neoplasms as well that metastasize to the brain, including the lung cancer, breast cancer, thyroid carcinomas, prostatic carcinomas, melanomas, colorectal carcinomas, and hepatocellular carcinomas. Ewing sarcoma and Langerhans cell histiocytosis has also been implicated in acute epidural hematomas. The majority of acute epidural hematoma patients experience a severe headache followed by neurological deficits, including the deterioration of consciousness or hemiparesis. Fragility of the newly formed vessels in malignancies, particularly due to the neoangiogenesis that happens, may lead to hemorrhage and the formation of a characteristic epidural hematoma. So if we move on, we find that there is something called as a spontaneous spinal epidural hematoma as well. Just repeating that there is a characteristic spinal epidural space which exists normally, unlike the cranium, which does not show any characteristic natural epidural space. So predisposing factors for a spontaneous spinal epidural hematoma include anticoagulant therapy, vascular malformations, hemophilia, and hypertension. Pregnancy-induced structural changes of the vascular walls and hemodynamic changes may also play a role in the pathogenesis of a spontaneous spinal epidural hematoma. So we look at the microscopy of it and we find that there is a characteristic hemorrhage that you see here, which has been highlighted. here with the arrow. Okay, and what do you see here? You see a characteristic vascular malformation in the epidural space, which has resulted in this hemorrhage. Now, what is a characteristic subdural hematoma? A subdural hematoma, unlike an epidural hematoma, usually arises due to a vascular rupture, which is particularly a venous rupture. Unlike an epidural hematoma, where the rupture of the vessel is particularly arterial in origin. So, an epidural hematoma is a rapidly expanding lesion with a characteristic involvement of the arteries, whereas a subdural hematoma is a slowly expanding hematoma with characteristic involvement of the veins. So, some cases are caused by blood from hemorrhagic contusions and traumatic subarachnoid hemorrhage that extends to the subdural space due to the tears of the arachnoidal membrane. Okay, so if there are some subarachnoid hemorrhage, it might extend into the subdural space due to the tear in the arachnoidal membrane. Other cases are caused by rupture of the characteristic vein, that is the emissary veins, which run between the surface of the brain and the skull and are especially numerous along the superior sagittal sinus. Now, if we come to the brain autopsy findings, we find that this is a characteristic diagrammatic representation which shows that there is a hematoma in the subdural space pushing the dura to the periphery. This is the autopsy finding, also showing a characteristic subdural hematoma, okay, where the hematoma is just below the dura and pushes the dura to the periphery, right? Now, the subdural hematoma starts as a flat blood clot between the dura and the arachnoidal membrane. Initially, it is not attached to the dura. Fibroblasts start growing from the dura into the clot and organize it. In 5 to 6 days, fibroblast growth causes the blood clots to be loosely attached to the dura. In 10 to 20 days, a loose fibrous membrane is formed between the dura and the clot, that is the outer membrane. Fibrous tissue then grows around the edges of the hematoma and along its inner surface, that is the inner membrane is formed, encapsulating it completely, right? After several months, there is formation of a sac with a fibrous wall, that is a characteristic chronic subdural hematoma develops. If we come to what is characteristically the big black brain. Now, what is this? Subdural hematomas in infants, not infants, are often accompanied by brain swelling and a characteristic loss of the gray-white matter differentiation. Okay, so what is this gray-white matter differentiation? As we can see that this is the characteristic gray matter and this dark area that you see within is the characteristic white matter. So due to hypoperfusion of the hemisphere underlying a subdural hematoma, there is loss of the differentiation of the gray and white matters, right? The involved hemisphere in survivors show characteristic severe atrophy and neuronal loss with gliosis in the cortex, right? So the microscopic picture will show you a characteristic neuronal loss, severe atrophy and gliosis, particularly in the cortex, basal ganglia and thalamus, okay, showing a characteristic picture of a hypoxic ischemic encephalopathy. Non-accidental traumatic brain injury is quite common in infants. Okay, so this is characteristically called as the big black brain. Now, what is subarachnoid hemorrhage? Now, this is already known to us. It's been discussed in the previous class as well. Subarachnoid hemorrhage is one of the most frequent traumatic brain lesions. It results from rupture of the corticomeningeal vessels and from the hemorrhagic contusions of the brain. A large subarachnoid hemorrhage raises the intracranial pressure, impairs cerebral perfusion, and causes characteristic hypoxic ischemic encephalopathy. Hemoglobin released from the RBCs in the subarachnoid space triggers what is called as vascular spasm. It is to be noted that this subarachnoid hemorrhage characteristically incites fibrosis of the arachnoidal membrane, and there is fibrosis of the arachnoidal granulations, as a result of which what happens is that there is impairment of the CSF circulation, resulting in characteristic hydrocephalus, okay, and a raised intracranial pressure. Now coming to the microscopic picture of it, what do you see here? You see large dilated vessels, okay, laden with RBCs and showing a characteristic hemorrhage in the subarachnoidal vessels. Now coming to what is diffuse axonal injury. Now, diffuse axonal injury is a special traumatic lesion which occurs most frequently in the motor vehicle accidents and following blows to the unsupported brain. Axons are stretched and do not snap from this injury. Their sudden deformation causes changes in the axonal cytoskeleton that leads to a characteristic arrest of the fast axoplasmic flow. The components of this axoplasmic flow include the mitochondria and other organelles which characteristically accumulate proximal to the lesion and cause characteristic axonal swelling or formation of axonal spheroids. Now, axonal cytoskeleton shows compaction of the neurofilaments, breakdown of the microtubules, and accumulation of the mitochondria within the axonal cytoplasm. So this is the basic component of an axonal spheroid. Axonal spheroid may contain neurofilaments, tubulins or actins, organelles like mitochondria as we've already discussed, electron-dense bodies may also be present, pathological proteins like the tau protein or the ubiquitin or alpha-synuclein, or it might just be empty and have small molecules like calcium. So how does it look like? This is what it is. These are the axonal spheroids, okay, showing a characteristic axonal swelling with pushing of the nucleus to the periphery, as you can see, and accumulation of what is called as particularly the organelles or for that matter neurofilaments. Okay. Now, axonal swellings are not only seen in traumatic brain injury, but they are also seen in infantile neuroaxonal dystrophies, neurodegenerative diseases like the Alzheimer's disease, brain tumors, and cerebrovascular accidents. Now, what is chromatolysis? Chromatolysis, as has already been discussed in the first class, this is a characteristic neuron showing a central chromatolysis. Okay, there is disaggregation of the rough endoplasmic reticulum and the neuronal body has characteristically ballooned. There are 3 normal neurons that you can see with characteristic rough endoplasmic reticulum. So central chromatolysis is a condition where the chromatin and the nucleus is pushed to the periphery of the cell, and this is a response to axonal injury. Now, what is the pathogenesis of diffuse axonal injury? There is influx of calcium through the stretched axolemma, probably which initiates the process and leads to the formation of these spheroids. Mitochondrial dysfunction and neuroinflammation contribute to the local tissue injury. Some axons with mild lesions probably recover, while many eventually rupture. Ruptured axons undergo characteristic Wallerian degeneration, leading to the loss of neurological function. So what is Wallerian degeneration? The process of degenerative events that occur in the distal axon after injury to the proximal parts of the neuron. Note, it is a degenerative process that involves the distal axon due to the injury to the proximal neuron. Okay. This pathological process involves a rapid axonal disintegration, breakdown of myelin sheath, and then activation of microglia or macrophages for that matter, with characteristic clearance of the tissue debris and gliosis. So let's see, what do you see here? We see the characteristic white matter of the cerebellum, which shows Wallerian degeneration, which is characterized by vacuolization of the myelin due to degeneration of the myelin protein, right? What do you see here? There is infiltration by macrophages in the characteristic Wallerian degeneration seen in the pontine tracts, okay, and there is abundant infiltration of these pale staining macrophages, which are here to clear the tissue debris. And the background shows characteristic gliosis, and these are the gemstocytes. Now, Wallerian degeneration occurs in many diseases, not only in trauma and stroke, but also in multiple sclerosis and Alzheimer's disease. Evidence suggests that Wallerian degeneration is one of the major causes for a non-reversible functional deficiency in these diseases. So now, coming to the significance of BAP. What is BAP? BAP is nothing but the beta amyloid precursor protein. It must be noted that the damaged white matter shows characteristic axonal swelling and axonal spheroids, which can be detected on HNE and silver stains, particularly 15 hours after the injury. But with immunostains to antibodies, particularly against BAP, that is the beta amyloid precursor protein, can detect the axonal injury in about 2 to 3 hours after the insult. Between 6 to 12 hours after the insult, a characteristic Wallerian degeneration, as we've already discussed, develops. Now, where does this BAP come from? BAP is produced by the neuron as a reaction to the injury. It flows down the axon and accumulates at the points of axonal constriction. So here we see the characteristic immunohistochemistry for beta amyloid precursor protein, which shows the characteristic axonal injury much before it is seen on the HNE. Axons in the white matter are especially susceptible to acceleration or deceleration injuries. But why? This is because of their viscoelastic nature, okay, anisotropic arrangement in the tracts, linear arrangement of the microtubules and neurofilaments in the white matter, and a large surface to volume ratio of the axon, or rather the axonal membrane or axolemma to the axoplasm. Now, distal to the swelling, axons and myelin degenerate and a gliosis develops over time, as we have already discussed. Severe diffuse axonal injury may cause a decrease of the white matter volume, atrophy of the corpus callosum, and a dilatation of the lateral ventricles. Right? So now, what is chronic traumatic encephalopathy? Boxers and football players are frequently affected by this chronic traumatic encephalopathy. It's been reported in athletes and involves characteristically individuals who are more susceptible to head trauma. The syndrome begins insidiously, usually many years after the patient has stopped playing the sport, with inattention, mood swings, and behavioral disturbances. There is often a confusion and memory loss, which subsequently upgrades to a full-blown dementia and a Parkinsonism. So what is the pathogenesis behind this? The cause of the chronic traumatic encephalopathy is thought to be the traumatic brain injury, especially the repeated cerebral concussions and subconcussive trauma. This, along with the cerebral hypoxia, excitotoxicity, and inflammatory mediators, set in motion a progressive destructive cascade that culminates into a neurodegenerative disease like Parkinsonism many years later. Now, what is the gross picture of it? If we see, let me just show you with a laser pointer. Okay, so this is the normal brain that you see here. Okay, whereas this is a brain of a chronic traumatic encephalopathy. What can you make out? There is a characteristic atrophy of the brain, a dilatation of the ventricles, and a thinning of the corpus callosum. If we see the autopsy of such a brain, we see that there is characteristic dilatation of the ventricles, atrophy that you can make out of the brain as a whole, okay, and a characteristic thinning of the corpus callosum. Now, we come to the microscopic picture of it. Microscopic examination shows a characteristic hyperphosphorylated tau protein deposition in the neurons around the small vessels. These changes are patchy and affect the deeper parts of the cerebral sulci. Astrocytes containing the phosphorylated or rather hyperphosphorylated tau are also present in the subpial cortex, but this finding is associated more with age and not with a repetitive head impact. It is clear that the neuronal hyperphosphorylated tau protein deposition is one of the key cellular changes in chronic traumatic encephalopathy. So let's see. What do you see here? You see a characteristic here, yes, you see a characteristic neurofibrillary tangle filament, okay, that has been deposited in the cytoplasm of the neuron. And this is the abnormally hyperphosphorylated tau protein deposition that is seen in chronic traumatic encephalopathy and also in cases like Alzheimer's disease. So what do you see here? We see a characteristic tau immunostain slide. Okay, and this tau immunostain that is used to highlight these neurofibrillary tangles. As we can make out very well that these tangles are somewhat flame shaped and some tangles are even band shaped here. Okay. Now coming to what is shaken baby syndrome. The term shaken baby syndrome describes a pattern of child abuse which is the second most common cause of death in children under 1 year of age after the sudden infant death syndrome or SIDS. Now grabbing an infant by the shoulders and shaking or jerking sets the head into a whiplash or dangling motion. What do you see here? You see that there is a damage of the neuraxis which results in characteristic apnea and the child starts crying because of the hypoxia. That subsequently results in cerebral edema, a raised intracranial pressure, reduced perfusion ischemia, and finally a hypoxic ischemic encephalopathy that culminates in axonal injury. So the triad of a shaken baby syndrome is encephalopathy, a subdural hematoma, and retinal hemorrhage. What are the effects? The major effect is encephalopathy. Okay, encephalopathy and death are mainly caused by this global hypoxic ischemic encephalopathy, which is the key pathology of the shaken baby syndrome, and a raised intracranial pressure. Cerebral edema, which follows a hypoxic ischemic encephalopathy, raises the intracranial pressure and makes this hypoxia even worse. What is the cause of this hemorrhage? The hemorrhage that results, that is particularly the retinal hemorrhage that results, is basically because of the vascular tears from the shaking that causes microscopic or large parenchymal hemorrhages. Now coming to cerebral edema, why does that develop? Cerebral edema in a traumatic brain injury, hypoxic ischemic encephalopathy, or for that matter brain tumors, meningitis, brain abscess and other pathologies is particularly caused by the accumulation of water in the interstitial CNS spaces, okay, due to increased vascular permeability. That is due to increased vascular permeability. When we are talking about that, we must remember the blood-brain barrier, right? So increased vascular permeability or increased permeability of the tight junctions of the blood-brain barrier results in characteristic vasogenic edema. And in some cases, there is accumulation of water even in the cells per se, resulting in characteristic cytotoxic edema. So vasogenic edema mainly involves the white matter more severely and extends along the optic nerves and into the optic papillae, resulting in what is called as papal edema. Now if we see the microscopic picture, we see a normal white matter. As you can see, you have lots of oligodendroglia that you can make out with a characteristic fried egg appearance. What about this one? This shows a characteristic edematous white matter where there is interstitial edema, okay, due to the break in the tight junction. So finally, we conclude with the effects of the head trauma as a whole. The neurological dysfunction and death in a traumatic brain injury are particularly due to brain injury itself, prolonged coma and its complications, infections from open wound or basilar skull fractures, hydrocephalus particularly arising from a subarachnoid hemorrhage due to characteristic fibrosis of the arachnoidal granulations, as we had already discussed, and particularly due to increased intracranial pressure. So why does the intracranial pressure rise? It rises because of the added masses of the epidural, subdural or intracranial hematomas, or for that matter due to cerebral edema which develops around large contusions from diffuse vascular injury and as a result of a hypoxic ischemic encephalopathy. Any increase in the intracranial mass will first displace the CSF into the spinal subarachnoid space. An increase of the intracranial pressure, anything above 40 to 50 millimeters of mercury, will cause a characteristic collapse of the brain capillaries, resulting in a global hypoxic ischemic encephalopathy, or for that matter, a global ischemia. So eventually, I'd just like to end with a saying which says that it merely takes a second to injure your brain, but it takes weeks, months, and even years for a traumatic brain injury to recover. Thank you so much for your patient hearing.